Hi, I'm Dr. Franklin. I'm an interventional cardiologist here at Emanate Health. Thanks for joining me, Internet, here for Ask a Doctor Live at Emanate Health. Today, we're here for American Heart Month, and we're going to talk about congestive heart failure and some valvular heart disease therapies we have here at Emanate Health, and we'll also touch a little bit on the COVID-19 pandemic, as that's still the most important thing going on in medicine. So I'm going to continue here. So if you have questions, you feel free to ask them in the chat box and we will address them at the end. But today, the agenda is to discuss congestive heart failure, some background, some therapies we have available, to talk about something called valvular heart disease, which is one of the main or major causes of congestive heart failure. Some valvular therapies that we have here at Emanate Health, and we'll touch on some cardiac manifestations of COVID-19 as well at the end. So let's start by talking about the heart. So the main function of the heart is to pump blood, and it pumps blood to our organs. So the brain, the kidneys, the liver, muscles, tissues. We need that blood because it provides oxygen for our organs to work. And the heart receives the blood from the body after all the oxygen has already been extracted. It then pumps the blood to the lungs after going through the right side of the heart. So basically you have veins that drain the blood into the right side of the heart there. You can see, here's my mouse, okay, so these blue vessels dump the blood into here, the right atrium, which then sends the blood to the right ventricle, pumps the blood into the lungs, which then sends blood and oxygen back into the blood, I should say. And then the lungs send blood back into the left atrium, this chamber up here, through the mitral valve here to the left ventricle, which is the main workhorse of the heart, which then pumps the blood back through the aorta to the rest of the body. So what happens if some of these things go wrong? So congestive heart failure. So we like abbreviations. We call this CHF. But essentially, CHF is a cardiac disorder which leads to the impaired ability of the heart to fill with or eject that blood. So the blood is not being pumped as effectively. So this ultimately can lead to backing up of fluid into the lungs or into the belly or into the extremities. And there's a couple different types of heart failure. So one type of heart failure that we traditionally think about is systolic heart failure. That's when your heart is weak, if the heart function, the pumping function of the heart is reduced. And so in this particular case, that left ventricle, that main pump is not squeezing normally, it's not contracting normally, so it can't push enough blood into the circulation, or not as much as it used to. Contrast to this to a different type of heart failure that we call diastolic heart failure. This is a situation where the heart function, the squeezing function of the heart looks normal, but the heart is stiff. So it cannot relax like it should, and then that can lead to improper filling. So both of these situations, a weak and a stiff heart, can both lead to what we call congestive heart failure and that backing up of quote-unquote fluid. So why is CHF important? It's unfortunately very common. Over 6 million Americans live with CHF. This was from a report in 2017, and that's expected to rise almost 50% by 2030. And CHF does get more common with age. The lifetime risk is somewhere between 20 and 40%, and it does affect folks as they get older. And there are over 1 million CHF hospitalizations yearly in the US, many of whom are in their older ages. And that, not surprisingly, will continue to rise as more people develop CHF. So, and why does this matter? Well, obviously, patients with CHF have a quality of life that may suffer, but it costs a lot of money to hospitalize these patients, and we have to find ways to keep folks out of the hospital, to keep them feeling well, even if they get this diagnosis. So it costed approximately $30 billion to take care of heart failure patients in 2012, and that's expected to rise significantly. And as we know, healthcare costs are a big issue in this country as well. So what are some symptoms of CHF? If the heart cannot pump the blood appropriately or fill with blood appropriately, you can have fluid backing up and you can retain it. So What can that lead to? Well, it can cause some generalized fatigue or weakness. Obviously, a lot of things can cause this, so it can be a symptom, but just because you feel a little fatigue does not mean you have CHF. You can get palpitations, so people with weak hearts or stiff hearts can develop arrhythmias or irregular heart rhythms. One of the common ones is something called atrial fibrillation that we'll touch on again later, but people can have a racing heart sensation from this. And you can also get symptoms of fluid retention, as we talked about before. So this can lead to fluid being retained in the lungs, and so you can get shortness of breath when you're walking or exercising, or even when you're just resting or laying flat. One of the manifestations of the fluid building up in the lungs is it tends to cause more symptoms when you're laying flat. So sometimes people will say that they have to sleep on more pillows, they have to prop their head up even further. So then maybe they sleep on one pillow normally and they're sitting upright in a recliner now because they can't breathe. Another symptom is swelling of the legs or the ankles or the knees, up to the knees, or a swelling in the abdomen. And people can also get respiratory symptoms. So you can get coughing, shortness of breath, obviously. It can make you wheeze as well. And it can trigger other respiratory issues. If you have a pulmonary issue, a lung issue, if you have emphysema or COPD, it can exacerbate those issues as well. And just an example of a puffy foot there. Okay, so how do you diagnose CHF? So first and foremost, we go by symptoms. So if someone is complaining of some increasing shortness of breath, some fluid retention, that warrants some further investigation. So a physical exam can maybe tell us if there's fluid building up in the legs or the lungs. We can listen to the lungs like that and hear fluid sometimes. You can listen to the heart, and sometimes you can hear a valve problem, or there are other certain findings you can find if a heart is having trouble. And then you can do further testing, lab work, or some of these quite common heart tests that we do. So EKGs, those are the stickers on the chest where you can take a look at the activation of the heart and the rhythm of the heart. There can be hints there. You can do a chest x-ray. Chest x-ray is not the best test for the heart, but you can look at the heart size. You can see some big obvious abnormalities of the heart on a chest x-ray, and you can also look at the lungs to see if there's fluid there. And an echocardiogram. So that's one of our bread and butter tests that we use for the heart. That's an ultrasound. Put a little jelly on a probe and you take a look at the heart from outside the chest wall, and you can look at the heart function, you can look at the valves, and you can see a whole lot more about the heart. If appropriate, sometimes we consider doing stress tests to look for blockages in the arteries of the heart, or sometimes we'll do even a step further, something called a coronary angiogram, where we go inside the body and take some pictures of the arteries to see what's going on, to figure out if there's blockages or anything like that. And so if we've confirmed congestive heart failure, the next step is to try and figure out why someone's having this issue, to determine cause. So unfortunately, there are a lot of causes of heart failure, and some people have a little bit of a mixture of multiple things. So one of the most common causes is coronary artery disease. That's cholesterol plaque buildup in the arteries of the heart. That can lead to not enough blood going to the heart. The heart pumps the blood, but it also needs blood to work. So if there's a blockage in an artery and it's not getting enough blood, the muscle can decline in function or suffer because of that. Or you can have a myocardial infarction, which is a heart attack, and that's when someone has an artery completely block up, and then that's a situation where they have chest pain, chest pressure, they're sweaty, they're going to the hospital, and maybe you're doing a procedure more urgently. One of the other causes of heart failure is valvular heart disease. So if you have a leaky valve or a narrow valve, and we'll talk about that a little bit later, but there are a lot of other causes that I won't touch on as much here, but uncontrolled high blood pressure, toxins, viral infections. So there are a lot of different viruses that unfortunately can attack the heart, but there are some case reports of COVID-19 affecting heart function and causing heart failure as well, and so on here. So let's take a look at what we do for heart failure. So the first thing to talk about is medications. There are a lot of different medicines that we use for heart failure. Almost all these medicines have been studied and have been proven to reduce the risk of hospitalization in folks with heart failure and to reduce the risk of death. And so I always feel for patients when they have a new diagnosis of heart failure. A lot of times we end up adding a lot of medicines, and it's not the easiest thing to do, to take medicines every day, and some of them do have side effects, of course. And so it can be quite a burden, but a lot of these medicines have been proven, scientifically proven, to keep people out of the hospital, to keep them feeling well. So I'm just going to go over some of them here. One of the more common medicines is a class of medicines called beta blockers. They end with lol. So these are metoprolol, atenolol, carvedilol, quite common medicines that we just use for high blood pressure as well. But what does this medicine do? It slows the heart rate down a little bit, just reduces the workload of the heart a little bit, and it can sort of relax the heart, and by doing so can improve outcomes. Some side effects, as all medicines do have side effects, so it can cause some dizziness if the blood pressure goes down a little bit too much. It can cause a little fatigue as well, so things to watch out for. Another class of medicines, these have long fancy names, but basically ACE inhibitors, or ARBs we call them. These are ACE inhibitors and ARBs. They block hormones generated by the kidney that can cause constriction of blood vessels, vasoconstriction, and they can also promote some degree of vascular damage. Now, these are normal hormones, but sometimes if they're secreted in excess, they can be harmful. So you can block some of these hormones and they can help to positively affect the heart. So ACE inhibitors, the common medicines for this are things like lisinopril or enalapril. These are also just blood pressure medicines as well. And then ARBs are things like losartan, valsartan, also common blood pressure medicines. What can these blood pressure medicines do? Well, they can lower the blood pressure, of course, so that's something we keep an eye out for. ACE inhibitors can cause a little bit of a cough, a dry cough. That's something we watch out for. And both of these medicines work on the kidneys, and they can cause potassium to rise a little bit, and they can, usually they are protective for the kidneys, but they can affect kidney function sometimes, so that's something we keep an eye on. There's a newer class of medicines where it's an ARB medicine added to something called sacubitril, and this is a medicine called Entresto. This is a newer medicine in the past 5-10 years or so, which has been found to be very, very beneficial and even superior to an ARB alone. And this has a little bit of a water pill effect and kind of helps to relax the heart and dilate the blood vessels a little bit to reduce the load. There are other medicines called, there's hydralazine and nitrate medicines. These are medicines, there's one of the medicines is called isosorbide or Imdor. These vasodilate the blood vessels. They can lower blood pressure and also reduce the workload of the heart. And to keep going here, diuretics. So these are a mainstay. A lot of folks are on diuretics. Diuretics are water pills. They can make you pee extra fluid out. It's both salt and fluid, and that can reduce the risk of fluid being retained. And spironolactone in particular has also been found to have very positive outcomes on heart failure. And the newest class of medicines that we have for heart failure, this was recently approved by the FDA. They're a class of medicines called SGLT2 inhibitors. This was originally a diabetes medicine, but it's actually been shown to be very, very effective in folks with weak hearts as well. And so even folks without diabetes now are starting to be prescribed this medicine. And it's been proven to also improve outcomes, reduce the risk of cardiovascular death. And this increases the amount of sugar or glucose that's excreted from the urine. So it can reduce sugar levels that way, and it can treat diabetes that way, but it also has been found to be very beneficial for fluid retention and for folks with heart failure. So those are the medicines. Now, what other things can we do? Well, if someone has blockages in the arteries, if they have coronary artery disease, we will address that, because if the blood's not getting enough, if the heart's not getting enough blood, it can't do its job. So we try and provide revascularize the heart, I should say. If there's blockage there, you can fix that with either something called an angioplasty or a stent placement. That's a procedure that we do minimally invasively. Or sometimes if there's a lot of blockage, you can do something called a coronary artery bypass surgery. That's an open heart surgery. We also address valvular heart disease, if indicated, and we'll talk about that. If someone has a very weak heart, it puts them at risk for dangerous heart rhythms, like we've seen, you guys may have seen on TV, or if someone has a dangerous heart rhythm, sometimes you have to put paddles on the chest and shock the heart. This is something that can be done internally if you implant a permanent device inside the body, kind of like a pacemaker. It can try and detect these heart rhythms very early on, and they can deliver low intensity, but they can deliver electrical shocks to the heart to try and eliminate these heart rhythms. Sometimes a heart can be weak, and you can imagine the heart as a pump. Sometimes the heart does not pump in a synchronous way, meaning there are different walls, and sometimes one side of the heart kind of contracts in first before the other side, and you have a little bit of a dysynchronous contraction. So there are special pacemaker devices we can use to try and synchronize the heart, which can also help the heart function. And in very severe cases, you can consider things like left ventricular assist devices. Those are implantable pumps that stay in the heart at all times and help the heart to do its job. Dick Cheney had one of these. And you can also consider heart transplants, where that's the next step up from an implantable pump, which are obviously in more extreme cases. What are things that patients can do for themselves? Well, as we talked about, there are a lot of different medicines, and so it's important for you to be informed, to know what medicines you're on, and it'd be helpful to know why you're on them and what they do. Keep a list and bring them to all your doctor's appointments. Check and record your weights. We advise people to do that almost every single day, because if your weight starts to rise and you didn't eat a huge dinner the night before, it could be fluid that's building up. Monitor your symptoms very closely. If you're feeling more short of breath, obviously more fatigued, that may be an early sign that fluid is building up. And you also want to manage your other conditions if you have any, for example, obesity, diabetes, hypertension, sleep apnea. All these other comorbidities, other diseases, can adversely affect the heart as well and can make it harder to control heart failure. So other things important to keep in mind. And then things that are easy to say but obviously not easy to do: get enough sleep, manage anxiety issues, because stress hormones can adversely affect the heart. Stress, manage depression. Yeah, good luck with that. It's easier said than done for some of these other issues, for what it's worth. Other lifestyle changes. Cutting out other factors that can worsen heart failure. So smoking, for sure, 1, 2, and 3. If someone's smoking, they have to quit. Excessive alcohol use, certainly other substance abuse, methamphetamines, cocaine, these things can really, really hurt the heart. Try and avoid non-steroidal anti-inflammatories. Those are called NSAIDs. Those are things like Motrin, ibuprofen. Try to adhere to a heart-healthy diet. So a DASH diet, low-salt diet. We don't know what the perfect diet is, but we think it resembles something like a Mediterranean diet that's more rich in veggies, fruits, less processed foods, low-fat dairy, nuts, legumes, fish, fatty fish, rich in omega-3s, poultry, rather than red meat. Try and stick with other, more chicken, maybe turkey, that sort of thing. Certainly reducing saturated fats, that sort of thing. And finally, exercise. So everybody should exercise, even if you have heart issues, even if you have a weak heart. Exercise is beneficial. So in general, the recommendation, 20 to 30 minutes of moderate intensity aerobic exercise. So not just weightlifting, this is walking, maybe a little bit of brisk walking, breaking a little bit of a sweat, at least 5 days a week. And you start slow. Don't run a half marathon the first time you go out. You got to slowly, gradually increase your exercise tolerance. Add 5 minutes a week. Try and get up to that 20, 30 minutes. And don't overdo it. Listen to your body. If you're getting chest pain, if you're getting really short of breath, talk to your doctor, and we'll figure out if there's something else we have to do. Another thing that we have available is folks with heart failure who had a recent heart event, like a heart attack, can go for something called cardiac rehab. So this is a supervised exercise program. We actually have a really nice program here at Emanate Health where they provide education, and they do a very closely monitored exercise program in association with your doctor. And this has been shown to reduce rehospitalizations and mortality, and it can improve quality of life. And this is just a little picture of our rehab here at Emanate Health. So I am zipping through this. I apologize, I have a lot of slides, but I wanted to get to some of the novel technology that we have here at Emanate Health, some of the specialized procedures that we do. So the heart here, looking at this again, let's focus more on the heart valves now. So this bottom chamber here, the left ventricle, is the main pumping chamber. It has to pump the blood out the aortic valve here. It's a door. It has to open and close. And so one of the one of the common issues that can happen with the aortic valve is as you get older, the aortic valve can harden, it can calcify, and it can stop opening up normally. So it can provide obstruction, it can cause obstruction to the flow coming out of the valve. And so usually people are not symptomatic from this until it is severe, but people can hear a heart murmur sometimes earlier on when it's very mild, and it's something that we keep an eye on. But symptoms of aortic stenosis, this narrowing of the valve, can include heart failure or chest pain. And we can identify this by an exam, by hearing possibly a murmur, or you can also see this with an echocardiogram. So that's one of the best tests we have for that. And this is what aortic stenosis looks like. The most common type of aortic stenosis is aortic stenosis that occurs with age. So we have 3 little doors, 1, 2, 3, on this valve, and if you develop calcification, these little chunks of white here, it can start to harden the valve and it won't open up normally. That's the most common cause of aortic stenosis. And typically we don't treat aortic stenosis until symptoms develop. Meaning if you start to get symptomatic from it, heart failure symptoms, chest pain, if you pass out from this aortic valve issue, that's when we talk about doing procedures for it. Generally, medications can kind of reduce symptoms, but they don't fix the underlying problem. In the end, it's a mechanical problem. The valve is not opening, and you need a mechanical fix. So one way to address this is something called a balloon valvuloplasty. That's sort of just a balloon that you put in there and you inflate it within the valve and you make some space. You kind of crunch it open, but that's very temporary. The valve will re-narrow. So the traditional way of fixing this valve is with an open heart surgery for an aortic valve replacement, a full aortic valve replacement. And that's what was done for decades now. But there is a new minimally invasive option that we do here at Intercommunity Hospital at Emanate Health, and that's called a TAVR procedure. And that's a procedure where you can actually replace the valve by going inside the arteries of the heart. And so this is what the valve looks like. It actually doesn't look so different from a valve that you get put in surgically with an open heart surgery, but basically there's an outer frame. This is one of the more, there are a few different types of valves that we use, but this is one of the more common ones we use. It's made by a company called Edwards. So basically you have a metal frame on the outside of the valve, and within the frame you have a prosthetic valve. So it's a tissue valve made of of cow tissue. And there are other valves that also use pig tissue. But basically this valve is placed inside this frame, and then we can put it in from the inside, and it opens up and just starts working. So here's a little video here. So this is us accessing a femoral artery in the leg, and you go up into the aorta, into the heart, and this is just a wire that we use to cross into the heart through that tight aortic valve, and this is a little tube that we put in through the femoral artery, that leg artery. And this first step here is this is what a valvuloplasty is. So this valve here is the aortic valve. It's calcified, hardened, and you can inflate a balloon in there and make some space, and that can sometimes help to allow that valve to open up a little bit better. But again, that's more of a temporary solution. So the more definitive solution here is to put in a valve. So this is the valve here, and here's a balloon over here. They separate them in the beginning so it's lower profile, so it's easier to get in the body. But then you put the balloon inside that valve, inside that collapsed frame valve, and you basically advance that into where you want it. And once we've figured out exactly where we want to put it, you can inflate that balloon, and then that frame will open up and anchor against the aortic valve, and the valve inside just starts working. And so this is sort of revolutionized, it really has revolutionized how we treat aortic valve stenosis. And this is a procedure where people come in the hospital one day and they leave the next, which has been pretty amazing for patients. And this is what it looks like when we're doing it. This is on an X-ray. So you can see this valve opening up. You open up that frame with the balloon, and it just, can't see the valve tissue with this X-ray, but it just starts working. So that's aortic stenosis. We've done probably about 200 or more here at Intercommunity at this point It's been a very successful program. I'm one of the operators. Dr. Batar is one of the main cardiologists that does this. He kind of launched the program along with Dr. Walter, another one of our interventional cardiologists, and they've done a really, really good job with really good outcomes, and patients have been very happy with their results. So a second valve I wanted to touch on here is the mitral valve. So this is the valve that sits between the left atrium. So the left atrium, again, this receives blood from the lungs. It sends the blood through this mitral valve to the left ventricle. When the left ventricle then squeezes, all the blood should go out the aorta forward. But if you have a mitral valve that's not closing well, when this bottom chamber squeezes, this valve, mitral valve, should close nice and tightly so that no blood squirts backward. But if this valve does not close appropriately, sometimes blood can go right back into that left atrium where it came from, and that can cause problems. So when blood flows backward from the left ventricle into the left atrium, that's called mitral regurgitation. So it's common to have a small amount of this. Everybody has some mild degree of this. So when we quantify how much you have, we can say trivial, mild, moderate, severe. So normal to have trivial, mild, but if you have severe regurgitation, you can have up to about half of the blood ejecting backwards each beat. There are a lot of different causes. Some can be very acute, just all of a sudden. That can be from a heart attack, an infection issue, trauma, or sometimes it's just from slow degeneration of a valve with age, or it can be caused by other heart disease where the heart maybe is enlarging and the valve gets stretched out. Okay, so if you have a very leaky valve, that can cause problems. These chambers, the left atrium and the left ventricle, can dilate, they can enlarge, and that can cause a lot of problems. One, it can cause irregular heart rhythms if the top chamber starts to enlarge. Two, you can develop heart failure, which we've talked about already. And then eventually the left ventricle, the bottom chamber, can start to enlarge and weaken as well because it's trying to handle a lot more blood than it's used to. And there are different types of mitral valve disease here. There's 2 doors on this mitral valve, and it's tethered by these little fingers connected to the muscle. But if you have a valve issue in and of itself where the doors just don't meet in the middle because one of the valves is too floppy, or there's a tear in one of these little fingers, finger-like projections, then you can get leakiness that way. The other way is if you have a heart that's enlarging, and that can lead to a valve that also can't close as well, and that can lead to leakiness. So a procedure that we do, I guess to talk about treatments, I'm sorry. So medical therapy, usually we can use medicines to try and prevent heart failure symptoms, but that's limited to symptoms. It again doesn't fix the underlying problem. And historically, an open heart surgery was the only option we had for this. But nowadays, we do have a minimally invasive procedure as well, called a MitraClip procedure, which is done through the veins in the leg. And so we reserve this for folks who perhaps have a high risk for surgery. They're a bit older, or they've had an open heart surgery before, or they have lung issues or kidney issues or liver issues, and open heart surgery is perhaps not the best choice. So this is what a MitraClip system looks like when we're putting it in, but this is the actual clip here. It's a little white, it almost looks like a clothespin, and what you do is you put it on the valve where the leakiness is worst, and that can reduce the amount of leakiness, and we do this all percutaneously through the blood vessels. So this is the bottom chamber of the heart again. This is the top chamber, and this blue blood, let me just start over here. This blue blood is the leakiness. This is blood going backwards from the left ventricle to the left atrium. And this is our device here. Okay. So we enter now through this. The blood vessels here are blue because they're veins, as opposed to the previous procedure where it was red, it's a heart. An artery, I should say. So we are crossing into the heart. We land on the right side of the heart because you're going through a vein, and you actually go through a little wall to the left side of the heart into the left atrium. And then you can place this clip from the inside here. So you can kind of move it around. We can see ourselves on an ultrasound and an X-ray. You can open up the clip, you can close it, and then basically we identify where the leakiness is worst, and then put the clip on. So that blue blood is the blood coming backwards. So you advance this clip here, past the valve, and you can actually withdraw it with the arms open, and you can catch both doors inside the arms. And you can latch on to the valve and reduce the amount of leakiness. And the nice thing about this clip is that you can open and close it. So if you don't like your first attempt, you can reposition, you can change the angle, and try and find a result that you like. And the valve's still opening, it's just opening in a slightly different way now, with 2 openings rather than 1. Okay. So, all these procedures that we do, there's a whole heart team that we have here available at Emanate Health that goes over every single case, and this includes a patient's primary cardiologist, the interventional cardiologists, myself, Dr. Pitar, Dr. Walter. We talk with the cardiac surgeons, heart surgeons, open heart surgeons are always involved because they have both sides of the coin here, and they can sort of try and talk about pros and cons of either side. We have a valve clinic that coordinates all these issues, which is really the heart of the, getting all these things done. We have a lot of nursing staff that has to be trained in how to manage this equipment and how to take care of post-op patients. We have a cardiac anesthesiologist in every single case who's very in tune with complex heart disease that needs to take care of these patients during the procedure. And then we have imaging specialists to sort of guide us when we're doing these procedures. So it's always a collaborative sort of decision and process when we're doing these procedures. That's something we call a heart team. So this is our team here. Loretta, Leighton, and Norma are in our valve clinic. They are sort of our go-to folks that help us keep in touch with the patients, who arrange all the procedures, all the pre-op and post-op testing, and they do follow-up. So they're incredibly helpful and incredibly important in the process here. We have interventional cardiologists here. We have surgeons. All our surgeons are USC affiliated here, and USC faculty that help with these procedures. We have imagers. We have very good anesthesiologists that help us out with every case. I was given 20 minutes. I'm sorry for going over, but I hope this is interesting so that you'll forgive me. This is a case presentation. I just wanted to show you a mitral valve case. So this is a 76-year-old woman. She had an open heart surgery in the past, had diabetes, hypertension, high blood pressure, cholesterol. She was having increasing shortness of breath just with minimal activity, just changing her bed sheets over the past 6 months. On a physical exam, she was found to have a murmur, a heart murmur, that wasn't as bad before. And on an echocardiogram and an ultrasound, she had a very leaky mitral valve. She was evaluated for open heart surgery, and she was deemed high risk because of a previous open heart surgery and because she was a little bit frailer than some of our other patients. So we decided to opt for this MitraClip procedure. So this is an echocardiogram and ultrasound that we do from inside the esophagus. So we're looking at the heart from inside the body. And to orient, this is called a transesophageal echocardiogram. To orient you, this top chamber here is the left atrium. That's that top chamber. This here is the mitral valve. It's got 2 doors on it, just like you saw before. And this bottom chamber is the left ventricle, the main pumping chamber. So we have this little box here that's sitting over it, and all these mosaicing of colors, this red, yellow, blue, green. So this is blood that's squirting backwards from the left ventricle to the left atrium. And that shouldn't be there. So this is our device here. We have a little shaft, this little line here, and then our clip. You can see in a couple of, it's probably better seen on this left side, but this is actually what the clip looks like. So not as pretty as the video that I showed you, but I guarantee you it's there. And then after you put it on, this is actually a 2-clip case, so we put 2 clips on there. So there's one here and one next to it. But you can see the color, there's dramatically less color here on this side and on this side. This is a simultaneous picture just from 2 different angles of the heart. And so just using these clips, we were able to reduce the amount of mitral regurgitation significantly. And this is what it looks like on our x-ray when we're letting go. This is the first one. So this whole contraption here has to come out of the body. We only leave the clip behind. So you kind of pull that back and you just leave the clip there, and it's nicely adherent there and moving well with the heart. And this here is the ultrasound probe that's actually inside the esophagus. And this shadow here is the heart, the big shadow here. Okay, very good. So she was discharged on post-op day 1. A follow-up echocardiogram showed just mild mitral regurgitation, and she was doing much better. Her breathing was improved, and she's been much more active since. So a really nice success story there. Okay. So We've talked a little bit about heart failure, about valvular heart disease and therapies that we have here. I did want to touch a little bit on COVID-19. Dr. Patar, one of my colleagues, did a very thorough talk on COVID-19 in an Ask a Doctor live session in November, so that was 3 months ago now. I won't go into as much detail as he did, but I will say, so COVID-19 has cardiac complications for sure, and folks with really, any other systemic disease, whether it be lung issues or diabetes or kidney issues, but especially heart disease, they seem to get hit harder with COVID-19, so we've definitely seen that. But some complications of COVID-19 are, it can make you more prone to clot formation, so you can get heart attacks from it. The virus itself can cause a lot of stress on the heart. It can cause cardiomyopathies, weak hearts, so it can cause heart failure. It can cause arrhythmias, so there's so much stress on the heart that the heart can go into irregular heart rhythms. And we've seen a whole spectrum of irregular heart rhythms, whether from being too slow on one end to being too fast on the other. And people develop arrhythmias like atrial fibrillation, atrial flutter, even some ventricular heart rhythms, some more dangerous heart rhythms that people need to get shocked for. It can cause shock, a dangerous lowering of blood pressure. It can cause the heart to stop. And like I talked about before, it can cause increased risk of clotting. So unfortunately, we see a lot of clotting issues in the veins, and you can also develop clots in the lungs that can also put stress on the heart. And we've seen, there's been a lot of studies done, but we've seen folks with other comorbidities, with other diseases, they have a higher prevalence of these diseases in folks ending up more sick. So people who are in the ICU or who don't end up surviving, they are the ones who tend to have underlying heart diseases. And unfortunately, it makes sense, because if you don't have as much reserve, if already at baseline you're not as well, it's going to be harder to get through an infection, especially one to this degree. And there have been some studies showing that there was a German study done where they looked at a lot of patients who had recovered from, or felt to be recovered from COVID-19. They found that 70 to 80% of those patients actually had some myocardial damage or inflammation on a cardiac MRI, which is a very, very specific test for looking for heart muscle inflammation or damage. We're not exactly sure what this means long term, but for sure there's lung issues, there's kidney issues that happen, but the heart is not spared. COVID-19 can also cause inflammation of the lining around the heart. That's called the pericardium, is the lining around the heart. So it can cause pericarditis. It's inflammation of the lining of the heart. And we can treat that with medications. But it can also cause inflammation of the heart muscle itself. And that can cause heart failure. That can make your heart weak. And so we treat that with steroids, which is also a mainstay of COVID-19 therapy as it is. But sometimes we're adding heart failure medicines like we were talking about before to try and lessen the load on the heart and try and support it. Sometimes people are very sick and they have low blood pressure, or their heart's too weak that it can't manage, and we have to start IV drips, very strong medicines to help support those things. And in very extreme cases, if the heart's really struggling, you consider mechanical support devices. So these are actually more or less devices, machines that you put inside the body to help the heart pump or do its job. And it runs a whole spectrum from balloon pump, which is a little more mild, to extracorporeal membrane oxygenation. That's like full bypass, where the blood is being routed, all your blood's being kind of routed through a machine, and the machine's doing all the work, all the way to a heart transplant. And then it can cause arrhythmias, like we talked about before, and it can cause these clotting issues. So a lot of folks end up needing blood thinners as well for various reasons because of these clotting issues that we see. But for more information about COVID-19 and the heart, you can refer to the talk by Dr. Patar a few months ago. He got very scientific. He went to a lot of studies. It was very, very thorough. It's a very good talk, so check it out. And it's on Facebook and YouTube. And that's it. So thank you. I'm going to answer some questions and open up for some comments as well. But I just want to close with, these heart issues we've seen with the COVID-19 pandemic, and understandably so, care has been delayed for issues. People have been having symptoms or issues with their other conditions, including cardiac issues, and they're afraid to go to the hospital. and that's completely understandable. But we strongly feel, don't delay your care. If you need to see your doctor, see your doctor. We have telehealth opportunities. You can talk to your doctor over a camera, over the phone. If you have to go to the hospital, go to the hospital. There's a lot of precautions we're taking. The numbers are coming down in terms of COVID cases. We do everything we can to separate, patients with COVID from other patients. So don't delay your care, because if you catch something too late in its course, we really want to treat things early on. So I'll leave it with that. So a question here: are there any advancements or advantages in bypass surgery? That's a really good question. So this is a big question that's kind of always comes up, especially even when we're doing our procedures and taking pictures of arteries and trying to decide what's best for patients. So stents are these little metal cages that you can use to open up arteries inside the heart if there's a blockage. Now, stents are very, very effective in treating certain types of disease. If you have one blood vessel that's involved, or maybe even two, and the blockage is maybe shorter, a stent is something that can thoroughly fix that very effectively. Now, if people have major blockages involving all three of the major arteries of the heart, or major blockages involving something called the left main artery, which is one of the major blood vessels that supplies about 2/3 of the heart blood flow, stents are still perhaps not the best treatment for that, because there is a risk of stents of re-narrowing. And if you're putting stents all over in every single blood vessel, or if you're putting it in very, very sensitive areas that provide a lot of blood flow to the heart, if that stent were to fail, there can be a lot of trouble there. So especially in folks with diabetes, the studies have shown that if you have diabetes, or if you have left main disease, that major branch, or three-vessel coronary artery disease, where all three major blood vessels are involved, bypass surgery is still felt to be superior. It reduces the risk of having to come back later to do procedures, and has been felt to be beneficial. Are there any advances in bypass surgery? Well, traditionally, we do, it's still done with an open heart surgery with a sternotomy, where they cut open down the middle of the chest. There are other techniques that are coming into the mainstream, and these are kind of like you've heard of robotic surgeries, or sort of minimally invasive surgeries for things like laparoscopic stuff for the belly. Usually that's like prostate, abdominal procedures, but there are robotic surgeries being started for heart surgeries, for bypass surgeries in particular. Now, the ability to fix all three blood vessels is still a little bit limited, because you don't have as equivalent an access to the heart when you're doing that open heart surgery. But that is something that is kind of starting to spread, and as new technology comes around. What should I do if there is heart disease in the family? That's a good question. It kind of depends on what the nature of the heart disease is. I would say things like coronary artery disease or cholesterol buildup in the arteries, that can run in families. And a lot of times it does have to do with other risk factors. So if diabetes runs in the family, or if high cholesterol runs in the family, that does tend to come hand in hand with heart disease blockages, cholesterol blockages as well. So I would say if that sort of thing runs in the family, the first thing to do is really preventative care. So make sure you don't get diabetes. Diet, exercise. If you have high cholesterol, stay ahead of it. If you have high blood pressure, stay ahead of it. Manage these conditions before they become something else. But it's never unreasonable to see your doctor and ask if there's more testing that's warranted, to see if you want to screen for some early signs of heart disease earlier on in life. Things like valve issues, leaky valves, narrow valves, they can run in families sometimes. So it's certainly not, it's not as clearly genetic as some other things, but there are certain types of heart valve issues that can come from genetics as well. So along a similar vein, it's reasonable to get screened for these sorts of things. But those are good questions for your doctor to see if there's anything else that needs to be done. If I have diabetes, do I need to see a cardiologist? How often should I go to a doctor? It depends on the nature of the diabetes. If you have very mild diabetes and it's under good control, I think a cardiologist, I would defer to the primary doctor in terms of if they're seeing any little warning signs or abnormalities on the EKG or symptoms to kind of warrant further testing. I would say if someone is diabetic, it does significantly increase the risk of heart disease, but if the diabetes is well controlled, it can reduce that risk. Other issues like high cholesterol are also things that we get a lot more aggressive with if someone is diabetic. So what we consider normal, quote unquote, normal cholesterol for someone without diabetes, unfortunately, a lot of times is not our goal for someone with diabetes. So it's a bit unfair, but we try and push cholesterol a lot lower in folks with diabetes just because we know that cholesterol buildup, atherosclerosis, that process of cholesterol building up, is just a bit more aggressive in folks with diabetes. So those are things that all need to be managed very closely. And how often should I go to the doctor for the diet? I mean, that depends on how well things are controlled. If someone has very well controlled diabetes on medications, then certainly the frequency of how often you have to see a doctor is going to be a little bit less. But if someone has uncontrolled diabetes, if the cholesterol is through the roof, these are things that up front we should be a lot more aggressive with. You should be seeing your doctor very regularly. You should be maybe seeing a nutritionist, trying to figure out ways to bring down those sugars as soon as you can, because if you have uncontrolled diabetes for a short period of time, that's a little different than having uncontrolled diabetes for years and years. And so it's just something that you want to get on early. Again, so that preventative medicine aspect. This is a good question. So CHF, the question was, the statistics say that we feel that congestive heart failure will increase in prevalence significantly by 2030, and how is that possible with all the progress in the treatments of heart disease, and why is it almost doubling in our lifetime? Well, that's a really good question, and I would say the prevalence of heart disease is continuing to rise because, number one, people are living longer, and so unfortunately a lot of times as we get older, things like diastolic heart failure and stiff heart disease, stiff congestive heart failure happens with age. It's almost invariably you will get it to some degree. So as people get older and as we are able to do procedures to help people live longer and to address coronary artery disease and these sorts of things, the older the heart is, unfortunately, the more likely it is to develop some form of congestive heart failure with time. Now, does that mean that we're going to have a lot more weak hearts? Maybe not. A lot of these numbers I suspect, are going to come from diastolic heart failure, which is the stiff heart syndrome, where you still get similar symptoms, but it's approached slightly differently than a weak heart, which can come from valve issues and heart attack issues and that sort of thing. If you have carotid blockages, is it likely that you have heart artery blockages too? That's an excellent question. The studies that have been done do show that they certainly can come hand in hand. It's a similar process that happens in all of the body. So the arteries in the neck, the arteries in the legs, the arteries in the heart, if one of them is filling up with a little bit of cholesterol or calcium, the others can as well. Now, in terms of incidence and prevalence, we tend to see it starting in sort of the aorta, the big blood vessel, and the carotids a little bit earlier than we usually see it in the heart arteries. But we can see it in both, for sure. So if we find that someone has some degree of atherosclerosis, either starting in the carotid arteries or starting in the aorta, that is a situation where number one, we start to institute some medications to try and reduce the progression of that disease, whether that's an aspirin or cholesterol medicine or that sort of thing. And that is the way to curb the development of cholesterol in the heart arteries as well. But we'll also potentially screen the heart as well with a stress test or further, certainly an EKG or other testing, to make sure that that if you have blockage either in the neck arteries or in the leg arteries or somewhere else, that it hasn't already extended to the heart, because that process can be quite diffuse sometimes, meaning it can affect the whole body. And so so we always want to make sure that if it's involving one area, that it's not involving the others. That's a good question. Okay. So that's all the questions I have for now. How do they wait for a little longer to? Okay. So thank you all for tuning in today. I hope this was enlightening. I hope that you learned something. Don't delay your care. See your doctors, whether it's a phone call or teleconference. Make sure you're not letting things, slide. Make sure you stay in touch with your doctors. And thank you again. And be safe, everybody. And hopefully this COVID-19 is behind us soon. Get vaccinated. Okay. Take care.